just a little bit about me here, which I won't bore you with too much. So without further ado, let's get straight into it. You can see an image, I hope, in front of you on the screen here, where you can probably notice two things. First one is pretty severe skin necrosis. And the other one, if you look very carefully, you'll be able to notice the difference in the pupils. So what we're trying to portray here is skin necrosis and visual disturbance. So these are the two dreaded most outcomes in aesthetic medicine that we are trying to avoid. And obviously, when we get to this stage, there's going to pretty much be an element of negligence involved. So normally when patients start having signs and symptoms, whether it's a bit of blanching, whether it's skin discoloration, visual disturbance, there's usually a time window, whether it's minutes, hours, or days before things eventually get to this stage. So there usually is some time on your hands that you have in order to try and diagnose and then initiate the management. Of course, blindness in itself is a little bit of a unique topic. So I'm not necessarily going to be covering blindness per se in this presentation because I have a whole new presentation just for blindness. But obviously, if you have any questions, feel free to ask me at the end. So this will be primarily focused on arterial occlusion causing skin ischemia. So what actually is a vascular occlusion? Well, I'm sure some of you have maybe seen them or it's happened to you. And what I'm trying to portray here in this presentation and this slide in particular is that whatever is reported out there in the literature is just what we are aware of and is the tip of the iceberg. Actually, there's a lot more that is happening around the world that goes unreported. So they're actually a lot more common than we think they are. So it's just something to keep in your mind, which will hopefully prevent us from becoming complacent when we're doing our injections. So how does it occur? So this analogy that I'm about to use is artery. And this will branch off into several different arteries, whether it's the angular artery, superior labial, inferior labial, and so forth. And each one of these smaller arteries will supply a small area of the skin, which is different parts of the leaves of this tree. So what will happen is if we inject, let's say, into the facial artery, blood pressure will cause the filler to dislodge distally, and then it will end up in one of the smaller arterioles. Now, whether it's the superior labial artery, whether it's the angular artery, inferior labial artery, we don't know because the filler can take any course that it wishes. And based on that, this is how we know that filler will travel into various aspects of the face, which I will come on to in a little bit more of a clinical methodology shortly. So extravascular versus intravascular. Some of you may have come across this, that if you put a lot of filler, a large bolus, for example, and you put this right next to the artery, this can cause a vascular occlusion. However, in 2016, there was a study done by Chang et al., and essentially they concluded that there's no such thing, and it's never been documented that you have an extravascular occlusion with filler, and that's led to full-blown necrosis of the skin. So that doesn't mean it can't happen. Theoretically, let's say if I were to put a large bolus right over here at the superior pole of the nasolabial fold, and I put a large bolus there, and there is compression against the facial artery, this may cause some element of blanching in the face. However, with a bit of gentle massage, and maybe even a bit of heat, this will dissipate, and this will not leave any long-lasting impression, like a true vascular occlusion when it's intravascular. So I don't think it's something that we need to be worrying about in particular. It's the intravascular occlusion that we need to be worried about. So this is a zoomed up image, so apologies if it's not very clear, but you should still be able to make this out. A bit like the tree. So here on the large blood vessel on the left-hand side is your external carotid artery. As we know, this heads towards the gonal angle, and it will spread into the superficial temporal artery as well as the facial artery. And this example here, you can see the needle is at the junction where the angular artery begins. Now, once you are injecting, let's say at this particular point, the filler within the syringe obviously comes out of the needle and it will travel back the way towards the facial artery because the diameter is a lot wider, so it's easier with the pressure for it to travel in that direction. Once you let go of the plunger, then the filler will dislodge distally, and then we cannot predict which way it's going to go. Will it go into the angular artery? Will it go into the supratrochlear artery, dorsal nasal artery? Will it go into the superior labial artery even? We don't know which way it will go, but at some point it will become dislodged and then obstruct the blood supply. This is what things look like on a histological level. So you can see here, this is a blood vessel. The D stands for distal, so that's the distal end. Now, the filler here, as you can see, is highlighted in black with the black arrow. So that's the white transparent filler HA gel that's been occluded in this blood vessel. And if you look very carefully where I have highlighted here in white, what you see proximal to this is stagnant blood. So there's reduced blood flow, and then what this causes is a embolism. So when we have an arterial occlusion, not only are we dealing with a filler embolism, but we're also dealing with the actual arterial blood embolism in itself. So a blood clot essentially, which is one of the reasons why we always give an aspirin before managing the patient. So this was a study done by a colleague over in Vancouver. This was done in 2015, and it essentially highlights all the cases of blindness and where the injections were in the face. If you look very carefully, you can see predominantly they were all in the midline of the face. So we're talking in the glabellar region, the nasal region, and the nasolabial fold. So this was in 2015. They repeated the study in 2019 and found further cases. And again, you can see the distribution is still somewhat similar to previously. So what are the clinical features of a vascular occlusion? So one of the first things that you're going to notice is blanching of the skin. Now, this may last a couple of seconds, it might last a few minutes, but there will be an element of blanching of the skin because of reduced oxygenation to the surrounding tissues. Often, and this isn't always the case, but we're talking about a very textbook vascular occlusion here, there's going to be associated pain. So you'll be able to tell this from the patient's facial response, for example, or they will just be very vocal about it, that it hurts. And then color changes. So this is not going to happen immediately. One of the first things that you might see is a bit of bruising. So first they will blanch, then it turns into bruising, and then several hours later, they will start having this mottled purple discoloration, what we call libido reticularis, which translates to impending death because there's ischemia involved. And a bit like a stroke, you know, when we have a stroke in the brain, there's an area that you can reverse. However, once it gets to the necrotic stage, you cannot reverse it. So ischemia can be reversed, not necrosis. So it's very important that we promptly recognize and diagnose a vascular problem, and then we initiate the management. So let's look at a real example here. This is an 18-year-old who's never had any treatments before with fillers. So she's injection naive. And she actually went to a very experienced, actually a friend of mine who's a nurse practitioner, and she wanted some lip fillers. This was now done with a needle. Nothing different was done, nothing fancy. She just wanted a little bit of enhancement. So have a very good look here at the before pictures on the screen in front of you. So straight after treatment, this is what we are presented with. Now, normally I would ask you and get you to answer back as to what you see. So just have a look there for a few seconds. So some people will say there's nothing extreme or out of the ordinary going wrong. But if you look very carefully, I guess some of you may argue that there's a bit of asymmetry in the lip, especially in the top lip. If you look very, very carefully, possibly you may notice, depending on the lighting, a little bit of discoloration near the nostril area. Now, the reason I'm showing you this image, because this was the exact same image that was sent to me following treatment. So again, this is what was going on through my head. I didn't think this was normal at the time. I thought there was something going wrong on here. However, the nurse at the time just thought nothing out of the ordinary here. The patient wasn't particularly complaining of too much pain immediately post-treatment. Whether this was because of the numbing cream, who knows? But this is how the patient left. So, as I said, what would you see? Is it bruising? Is it hematoma, a bit of swelling, inflammation? Or is there something a little bit more sinister going on, like a vascular problem? So, let's fast forward 2 days. So, this is how the patient started to present. So, what do we see here? So, we can see color changes. We can see mottling. And we can also see evidence of pustules and pus being formed, most likely because of deoxygenation to the tissues, and then there's bacterial colonization, hence what you see in front of you. You can also see significant bruising as well around the lip and just in general the perioral region. So what is a differential diagnosis here? Is it an infection or is it a vascular problem? Because they're probably the two things that will be going on in your head. And here, this is the patient when she presented with me, and what I've done here is I've drawn the vascular supply just more for educational purposes, because here it just shows how well connected the facial supply is. So nothing was done in the nasolabial fold, nothing was done outside of the lips, but a simple injection gone wrong in the lip, and there was retrograde flow, so backwards into the facial artery. So the needle would have been in the superior labial artery. It's gone back into the facial artery, and then it's gone forward towards the angular artery. And then you can argue that the smaller segments of the filler would have occluded the subalar artery as well as the nasal artery as well. So you can see a lot of vascular clinical features here. So what are the main things to do? Pain score and the cap refill. So remember, this is a couple of days post-treatment. So the patient at this point in time was saying this is very painful, very uncomfortable, very painful, had taken some painkillers, nothing was helping. And then what else can we do in treatment, in the treatment room, in the clinic room, is the cap refill. So this is when you would apply pressure for a few seconds with your finger, take it off, and then usually within 2 seconds, you'll see healthy reperfusion. However, it was delayed in this patient. So cap refill, pain, and visual signs and features is what we can see here. So just to summarize that, here what we have is basically the signs and symptoms of a VO. So it was uncomfortable, there was color changes, we can see evidence of mottling here, we can see skin breakdown, and the cap refill, which you can't see here obviously, but the cap refill was reduced. I believe it was around 3.5 to 4 seconds. So what is the antidote here? So hyaluronidase, often we give it the nickname Hyalase. This is your solution essentially to manage vascular problems with hyaluronic acid. So first thing that we did, and we do this on all patients, is warm compress. Why is this? Because this is going to cause vasodilation. In turn, that will increase oxygen levels to the tissues. Remember the diagram I showed you earlier on about not only having the filler that's causing the occlusion, but proximal to this, we also have a blood clot, so an actual arterial embolism to deal with too. So there's no point dissolving the filler when the embolus behind it will then also cause similar symptoms. So this is why we would give aspirin, which is a high dose. and then we would administer the hyaluronidase. Now, there's going to be a lot of questions as to, well, where do you inject it? How many units do we inject? What depth do we inject in? Which I will cover shortly. And then we want to consider adjuncts. Now, antibiotics are more, I guess, for a prophylactic point of view, if there's tissue breakdown, and same with steroids. If there's severe ischemia going on, even borderline necrosis, or there's a lot of inflammation in the area, steroids will also be a good shout. But the mainstay of treatment will always be two things: aspirin and hyaluronidase. Now, this is how it worked out in the end. Okay, so we can see here she was dissolved and then actually retreated eventually. And you can see here she's now ended up with a very nice set of lips. Just give me a second here. Okay, so I will come on to the hyaluronidase because I did say to you, where do you inject it? How much do you inject and what depth? But let's cover a few things first. So things to keep in mind when you're injecting. There's no safe part of the face to inject. There's either a safer area or a higher risk area. Generally speaking, if you look at the studies that were done earlier on in this presentation, that highlighted where most vascular problems, especially blindness, occur in the midline of the face. Well, this diagram kind of highlights to you why that is the case. Your major blood vessels, especially the ones that will supply the back of the eye via the internal carotid system, typically lie in the central part of the face. So this is why personally, I would consider glabella, nose, and the nasolabial fold as the three very high risk areas to be treating, as well as temples as well, in general. So some practitioners will think that they are absolutely safe when they start using a cannula. Now, in the time that I've been injecting, I've actually had a vascular occlusion myself on one scenario, which was done with a cannula, and it was done in the nose in a post-surgical patient. So the point here is that you can still have vascular problems even when using a cannula. Okay, so it doesn't mean you're exactly going to be safe. Granted, you might be a little bit safer, but you can still run into vascular problems. 25 gauges cannula that I use is my preference. It's not too big, it's not too small. And again, it's all going to be based down on personal preference. Aspirate or not aspirate. Now, again, over the years, some of you may have heard me saying this before, over the years that I've been injecting, I have never aspirated. And I guess this is one of a few studies out there which highlight that essentially, if you aspirate, it does not always mean that you are in a safe place to inject. Okay, so in this study, there were 340 individual aspiration tests, and essentially they found out that only a third of them were actually true. So that means in 2/3 of the time, they were actually still in a blood vessel, but the result came back negative. Okay, so just something to bear in mind here. It's a very powerful study, this actually, which just proves that you can't rely on aspiration. And a lot of injectors out there in various countries will always, there's two things they often say. One, oh, I use a cannula, so I'm safe. Not necessarily the case. Or secondly, they'll say, I aspirate. Again, that does not necessarily mean that you are safe. So just take those things, with a pinch of salt, using a cannula and aspirating, and then put all of your knowledge of facial anatomy together when injecting and treating your patients. Blindness, again, something I'm not going to go into too much detail, but there is a formal diagnosis algorithm, if you like, for blindness. And the image that I showed you right at the beginning of the presentation was ophthalmoplegia with ptosis, which is something that you want to avoid. Now, there is no treatment algorithm for visual loss with dermal fillers. Okay, there is just absolutely no protocol out there. There's a lot of proposed mechanisms of what we can try to salvage somewhat some of the vision, but nothing has a lot of evidence behind it to say it's going to work. Previously, there used to be about a 90-minute window between the patient saying something's going a little bit blurry, I'm losing my vision, to absolute vision loss. So you've got a 90-minute window to try and sort that out. Now, recent emerging evidence is saying this is as little as 15 minutes. So as soon as the patient starts saying, my vision is going a little bit blurry, you've got about 15 to 20 minutes to do something about it before their vision is completely gone. I will skip this slide because this is to do with trying to do retrobulbar injections. So unless you have a specific question behind this, feel free to ask me. But this is, again, trying to reverse so-called blindness, which is just not going to happen, nor is there any evidence behind it. So prevention is always better than cure. And knowing your anatomy is also going to be important. The single most important thing is the depth when it comes to injecting. Whether you're using a needle or whether you're using a cannula, it's always to do with the injection depth. So what should you keep in your toolkit? And I haven't forgotten to discuss the hyaluronidase, because how much do we use, where do we use it, and where do we place it, and how do we place the hyaluronidase is something that I'm going to talk about right at the end. But these are the things that you need to be keeping in your kit, these two things. So if you don't have these two, then that can be considered as medical malpractice or even medical negligence, because yeah, why would you inject a patient without having access to these in your clinic? Topical GTN, it's very controversial. It's not something that I use. Instead, I prefer using systemic vasodilators, such as sildenafil. Antibiotics, it's useful to have access to or a prescription for. Same with steroids, antihistamines, warm compress, obviously, bacterial culture kit, and just having some numbers where you can, refer the patient to. So, for example, having an ophthalmologist that you can refer to should patients start complaining of visual symptoms. So just some tips here to try and avoid disastrous complications. Now, the first one is going to sound quite controversial, because I know I don't aspirate, but again, it makes sense to aspirate, especially in higher risk areas, which are temples, glabellar region, the nose, and the nasolabial fold, even the forehead if you are doing forehead fillers. So it makes sense to aspirate in higher risk areas, but don't rely on aspiration alone. There must be other features that you need to keep in mind, such as facial anatomy. Inject slow, inject a small amount of product, potentially even use a smaller syringe if possible, which is ideal when doing certain high-risk procedures, such as the non-surgical rhinoplasty. Again, using smaller needles, using cannulas where possible, for example, doing the tear trough area, doing the upper eyelid region, eyebrow, or even forehead fillers as well. Patient selection, product choice, again, try and stick to HA-based products where possible, and then know your anatomy as well. Now, I'm going to take this back up to this slide here. So, where did I administer the hyaluronidase? Now, you have to, so often the answer that I get from a lot of students is wherever the filler was placed, that's where we are going to dissolve. But the actual answer is, where do you see vascular compromise externally, i.e. on the skin? That is where the symptoms are, and that is where you are going to be administering the hyalase. So in this scenario, you won't just inject the lip, you will also be injecting the nose. So let's say after lip filler treatment here, she had no signs and symptoms in the lips whatsoever, but she only had the nasal symptoms. Then you will only administer the hyaluronidase in that area. You won't need to put it into the lips, even though that's where she was initially injected. So hopefully that makes sense in terms of where you inject the hyaluronidase. So you're essentially always injecting where you can see the signs and clinical features of a vascular compromise. How many units are we injecting? So it comes in a 1,500 unit vial. I like to do 3 rounds of 1,500 units. So not necessarily 3. I could do 1 round. I could do 6, 7, 8 rounds. But each time you are going to do 500 units, and you will then wait 45 minutes, and then you will repeat. Now, first of all, why do I wait 45 minutes? Well, that's the half-life of the hyaluronidase. It's between 45 and 60 minutes. Secondly, how many times do I do it? Well, this is where capillary refill time is very important. So you would administer hyaluronidase, you would check the capillary refill time after a few minutes, and it should eventually return to normal. I recall, and I published a study on this actually, there was a patient who was injected with calcium hydroxyapatite. We did various things to try and reverse this, but essentially the capillary refill time to begin with was 7 seconds in the lips and the chin. 7 seconds. And after every round of hyaluronidase, it was eventually going down to about 3 seconds, which we were eventually happy with. So administer the hyaluronidase, 500 units, every 45 to 60 minutes. Check the capillary refill time. Once you think it's back down to approximately 2.5 seconds, then you can stop the treatment with hyaluronidase. Now, I know a healthy cap refill is less than 2 seconds, but don't forget, every time you're administering liquid, you're creating some internal pressure and swelling. So don't expect it to go exactly down to 2 seconds. But you should see a great improvement. In terms of how deep you inject, again, you are going to be subdermal. Okay, so not too superficial and not too